Can everybody hear us? Yeah, okay. Great to have you all with us today, and I'd like to welcome both Yogesh Bhatt and Neeraj Goyal, who are going to do a double act for us today. Yogesh will talk to us from his perspective as a head and neck surgeon, and Neeraj will talk to us, of course, from his perspective as a clinical oncologist. So we'll have both sides of the coin around this particular issue. And I know that one of the things that is a challenge for us in primary care, we often get people talking to us about lumps in the throat, or worries about swallowing, or things that they feel in their throat, and some of them specifically will talk about their thyroids. It's often very difficult for us to pull the various aspects of that apart, particularly as it's been difficult for us to access imaging in these recent months with COVID. So I know that they're going to talk us through a bit of that, so that we've got a few more skills in our back pocket to manage that sort of thing. Thank you very much. So I think Yogesh is going to speak first, and I think I'll let you introduce yourself and talk a little bit about what your particular interests are, and then we'll go on to Neeraj. Thank you so much.
Thanks very much, Claire. So yeah, my name's Yogesh Bhatt. I'm an ENT and head and neck surgeon based at Royal Free London. I've been there for about 5 years now. I've been CD for 4 of them, and am clinical lead for the Thyroid Cancer Service. And I'm very grateful to work with a fantastic bunch of colleagues, one of which is Neeraj, who's on the call today. And we manage a quite substantial cancer network that runs up to Essex and into Camden and across into Haringey. My other hat is as pathway director for head and neck cancer for the Alliance and for the East side also. Yeah, hopefully you get a lot out of it. And you know, I've written it very much with a GP sort of perspective in mind. Yeah. So Neeraj, do you want to say a quick hello before we start with the main presentation?
So yeah, my name's Neeraj. I'm one of the oncology consultants, and I work cross-site with North Middlesex Hospital, Chase Farm Hospital and Princess Alexandra Hospital, and I cover both thyroid cancers and breast cancers across that stretch. So thyroid cancer wise, I'm MDT co-chair with Yogesh. We've worked out a lot of these pathways together, which will hopefully make a little bit more sense for you guys as well. And I also deliver any external beam radiotherapy over at North Middlesex Hospital. And then personally wise, I'm also clinical lead over at Princess Alexandra Hospital. Yeah.
Super. In which case, let's make a start with the talk. So, Catherine or Vanessa, if you could advance the slide. Fantastic. So this is the patch. This is our patch, the NCL patch. So just to describe to you the sort of population that we serve, I think it is 1.5 million, I believe. And so we've got a network of diagnostic centres at Chase and Barnes in the Free. And we have colleagues who refer in from their diagnostic centres at the North Mid and in Harlow. Surgery is centralised onto the Free. Radioiodine therapy is grouped with Neeraj looking after the North Middlesex up into Essex, and Arun Carr working at the Royal Free. And we also have a system of stratified follow-up with local oncology services also, if we could advance the slide. So the objective of this talk is really twofold. One is for us all to leave with a better understanding of what thyroid cancer is and isn't, and how things have changed. They have changed remarkably in the last 10 to 15 years. And the second is more with a sort of pathway director hat on with regards talking about diagnostics and, dare I say, overdiagnostics or overdiagnosis even, which is an epidemiological term as opposed to that you can apply for an individual patient. But I think these two objectives are really important for what we do as clinicians, and hopefully we can achieve them both today. If you could advance the slide. And next slide. So we're really grouping this into 3 little presentations for you. The first is surgery. The second part will be Neeraj talking about oncology and follow-up, and the third is me talking again about epidemiology and thyroid nodules. So a quick anatomical refresher: the thyroid gland is an endocrine organ developed in the foramen caecum, descends in front of the larynx and trachea, and it's bound to that by Berry's ligament. and it's separated from the larynx by Joel's triangle. Around this area we have the recurrent laryngeal nerve near Berry's ligament and the superior laryngeal nerve in Joel's triangle. We've got parathyroid glands. So that's all the important anatomy. On the right hand side is a list of conditions that I would typically see in a typical clinic. And I think it's really important that any one of us who surgically treat thyroid cancer have a good understanding of the surgical treatments of hyperparathyroidism, which goes hand in glove, and also that we recognise the mimics, those things that might come across on initial consultation with patients to represent compressive symptoms, conditions like globus pharyngeus, which are not remedied by surgery to the neck. So if you could advance the slide. Fantastic. So a bit of background history to the service in the department. Starting at the bottom on the left is Mr. Berry, James Berry, who was a thyroid cancer surgeon at the Royal Free in 1891, and one of the first effective thyroid surgeons in the country. In the middle is Cecil Joel of the Joel's Triangle, who was a consultant in the department in 1931, and most significantly is Thomas Dunhill, who's on the right hand side. Now, Thomas Dunhill wasn't a surgeon in our department, though he was a surgeon in Hampstead and set up the North End Thyroid Clinic that was really the forerunner to lots of thyroid MDT clinics, and that sort of spawned the European and American Thyroid Association. So really lots of history in the service. If we could advance the slide. And around the time of James Berry in North America, we had the Mayo family. So on the left-hand side, extreme left, is Charlie Mayo, and Charlie Mayo cut his teeth, as it were, on thyroid surgery in the iodine-depleted Midwest. So lots of people with multinodular goiters. And what that meant was the Mayo Clinic grew into a large thyroid service and ultimately a thyroid cancer service once radioiodine was established as therapy. So they've really laid down the surgical and oncological paradigms that we were using for most of the last century, really. At the bottom is a thyroid follicular cell, and what's really key to us is the NIS protein at the bottom, the sodium iodine symporter, which is essential for the effective use of radioiodine. Just a quick point, it's a talk on thyroid cancer, but it's really a talk on differentiated thyroid cancer. So cancer derived from that cell. We don't have time, unfortunately, to talk about anaplastic. We don't have time to talk about medullary, though medullary is a core interest in our department because we work hand in glove with the neuroendocrine service, and lymphoma is something slightly separate, but may present a lot like anaplastic, so it's not something that you'd easily miss. If we could advance the slide. So this was the paradigm. Sorry, if we go back a slide, that's the paradigm that was laid down in the 1950s and 60s, which is thyroid cancer mandates total thyroidectomy, radioiodine in order to improve life expectancy, lifelong suppression of TSH, and then we monitor, once we developed immunoassays, monitor for the serum thyroglobulin to see if we had tumour recurrence. So all these things were true for large volume disease that was being identified in the 50s and 60s in Minnesota and all those patients that the Mayo Clinic was treating, but things have changed. So if we move on to the next slide, this gives you a good understanding about what it means to have thyroid cancer from a survival perspective. So it's about prognostication. So what you have on the left-hand side is TNM7, so the TNM7 staging system, which really describes prognosis from thyroid cancer, and on the right-hand side is how it's been changed slightly in 2016 to be TNM8. But the take-home message is that stage 1, 2 and 3, as it was in 7, has a pretty good life expectancy, and the number of patients who exist in stage 4 is actually very low. So most patients with differentiated thyroid cancer have a good life expectancy, and the issue then is, the principle then is, if they're going to be living a very long time, then you can't be affecting treatment that really that harms them, because they'll be living a long time, and the significance of them experiencing a cord palsy or hyperparathyroidism is really going to impact their quality of life. So we're really mindful of quality of life issues when we care for these patients. If we advance the slide. And that's the breakdown, effectively. So very simple and straightforward. If you have a patient who's under the age of 55 and they don't have distant metastasis, they are stage 1, and they have a life expectancy of almost 100% at 10 years. If you have someone with distant mets and they're under the age of 55, their life expectancy is also pretty good. and that's 85 to 95%, even with distant meds under the age of 55. So that's a really key message here, that the life expectancy is good, but these patients live a long life, and so we ought to minimise morbidity. There was some change when TNM shifted over from 7 to 8, and the key change was about neck nodes, that the presence of neck nodes doesn't substantially prejudice the outcome. It's really local invasion into strap muscles to a point, invasion into trachea and nerves very much. If we could advance the slide. Great. So this is the work in the diagnostic clinic. The question is, what do we do when we see a patient who has a thyroid nodule? And it's about risk stratification ultimately, and it's about identifying those patients who we think have a clinically significant lesion that would benefit from further assessment by a needle sample, and indeed might benefit from diagnostic thyroid lobectomy. So it all starts with the ultrasound scan. And the ultrasound scan is risk stratifying the patient. What we're asking is, what do we believe is the underlying level of risk in that nodule? And there are lots of different systems of doing that. But once we've established that a nodule doesn't have wholly benign features, we start to investigate by needle sample. So the diagram on the right describes the positive predictive value and negative predictive value of any given test. But the point is that you can't interpret the test unless you have an understanding of the pre-test probability of malignancy in that population, or indeed that nodule. So being able to risk stratify the nodule is really essential. So if we could advance the slide. So our friends in Europe were there before we were. This is a friend and colleague. This is Gilles Russ, and Gilles is radiologist in Paris. He works at the hospital Pitié-Salpêtrière. And Gilles developed for France a ultrasound reporting system. So ultrasound's really advanced over the past 20 years, and the BTA in 2007 suggested that maybe it had value. And in 2014, they realized actually that's where all the interest was at. The Europeans and the Americans were there before us. And so Gilles developed this, this system for France. So it's based on an American system with tweaks. There's a size criteria that they use that we don't. So, you know, one of the really important messages is it's not essential to be using any given criteria, so long as that across international boundaries. It's just really important that for any given sector, for any given region, we use the same criteria. It's about consistency rather than getting it right all the time. So if we can move on to the next slide. This is what we did in the UK. So a colleague in Birmingham, Steve Colley, works at the QE in Birmingham, and Steve and his colleague Rodri Evans looked through the evidence and established a stratification system that would work for the UK. So this was developed in 2014, and it was a game changer in how we diagnose and manage patients with thyroid nodules. Prior to 2014 guidance, the suggestion was that every nodule that you identify needs a needle sample, and potentially a needle sample twice, for us to be reassured that this represents a benign structure. But recognising the substantial advances in B-mode ultrasound, we've identified that there are lesions that are incredibly low risk and should not be treated as cancers or potential cancers. So if you look at the very bottom, a cyst doesn't contain any solid tissue, can only be benign. The second to bottom, very low suspicion, we call that U2, spongiform nodules, again, lesions full of colloid, very little risk. We wouldn't consider a needle biopsy. The interest comes in that third group, which is low suspicion, 5 to 10%. They're the U3 nodules, and that's what most commonly is referred onto our service. And there's an ongoing conversation about what might constitute U2 versus U3. But effectively, any nodule that's U3 and above might warrant a needle sample, so long as it's greater than 1 centimetre, and we'll talk more about that later on. So if we advance the slide. So we have an ultrasound scan, we have cytology, and oftentimes that can give us a handle on whether we should be talking about diagnostic surgery, therapeutic surgery, or not. But there is that grey in between area. both for radiology, they call it a U3 nodule, and also for cytology, we call it a Thy3 cytology. And in order to try to see whether we could tip the balance and understand whether that lesion actually was more likely to be cancer, whether we could rule in the cancer, ancillary tests were developed. And so these are two tests available in North America, the Affirma test developed by Veracyte and ThyroSeq developed by Yuri Nikiforov in Pittsburgh. We typically don't use them in the UK. To my knowledge, it's not a straightforward test in as much as we need to be sending them off outside the country. Might there be value in using the tests? Yes, we think so. On the left-hand side is another friend and colleague, Brian McIver, who's an endocrinologist and co-chief of the Moffitt Cancer Centre. And Brian conducted a real-world study of these tests, and what he found was that it has some value, but it's not. It wasn't the game changer that we anticipated it to be. So if a patient were to ask about molecular diagnostic tests, they are of value in specific circumstances, but they're certainly not going to be replacing good cytopathology. If we move on to the next slide. So ultimately, thyroid cancer, so long as it's of a reasonable volume, is a surgical disease. In as much as we treat it surgically, we are not treating it with medical therapy, and surgery carries with it some risk. And so these are the typical risks that one might inform a patient at the time of diagnosis. So there is a 1% risk of potential neck bleed postoperatively requiring return to theatre. The most talked about risk, of course, is that risk to the nerve of speech and swallow, or of pitch change. So the recurrent laryngeal nerve or the external branch of superior laryngeal nerve is at risk. Thankfully, the risk of bilateral cord palsy is very low. Hypoparathyroidism, potentially an issue, and dissatisfaction on levothyroxine, also potentially an issue. So, you know, the item that we think very hard about is cord palsies and what we can do to minimise them. And that's a diagram of a vocal cord paresis, leaving patients with a weak and breathy voice. And for that reason, I'm very mindful about listing patients with benign disease, simple benign disease, for thyroid surgery, given the potential risks. If we advance the slide. So this is us in the UK, assessing our risks as individual clinicians and being transparent. So this is the BAETS data set published in 2015. So the take-home message here is that the risk of cord palsy, as assessed by surgeons who assess all their patients' larynxes post-operatively, is up to 4%. And if you don't assess the larynx, the risk is 2%. And perhaps it's not that surgeons who assess aren't quite as good as those who don't assess. Perhaps it's that patients have silent paresis. And the diagram demonstrates that it's not simply surgeons who don't operate at high volume who don't assess. Actually, there are lots of high volume surgeons who don't routinely assess. Now, COVID intervenes here because nasal endoscopy is an aerosol generating procedure. And it may be that more of us choose to be selective in our assessment of the larynx postoperatively. So that's something to be mindful of going forward. And important also for us all to declare to our patients our personal palsy rate, which we should all have an understanding of if we advance to the next slide. Great, so that's for me. That's me done for the first bit, and next is Niraj.
Good afternoon. Thank you very much for letting me present. I won't spend too long, and hopefully we can move back to Yogesh and some questions. The idea of my section really is to give you an idea of our thought processes within the MDT, and how we then follow up and decide on things like TSH levels. And the reason we concentrated on this a little bit is we do get a lot of questions from GPs about what to do with thyroxine and TSH levels, so hence we thought they might be of interest. So this is an overview of really, I guess, how we look at the patients in the MDT. So, and this is from the ATA guidelines, I think, but the BTA is pretty much the same as well. So the idea is we look at their histology in our MDT, and from there we determine what TSH level we're looking at, the risk for recurrence, less so about mortality, unless of course they are locally advanced or very heavily node positive, laterally in the neck, centrally less of an issue, usually from a mortality point of view. And then from there, we can decide what their responses and treatment are and how we then follow them up. So from a radioiodine point of view, don't worry too much about the slide. I'm not expecting you to remember anything about radiation physics or anything for if you ever did it as a medical student. But basically, by giving them radioiodine, we're using beta particles, which means it's very localized from a treatment point of view. There is some gamma particles which escape, which is the reason why those patients then have to be isolated for a period of time, whether that be at home or whether that means they come into hospital for a couple of days. This over here is just the scans that we tend to look in the MDT, and these two pictures are probably the most common that we see, which just suggests that there is uptake within the thyroid bed. So then once we've given them the radioiodine, we have to look at what we're doing with the TSH. And we usually use 3 levels, so it's less than 0.1, which obviously requires the highest dose of thyroxine. The intermediate level, so 0.1 to 0.5, probably the fairly easy to reach. And then that level, basically anything less than 2.0 is fine for the low risks. And we're hoping that as we go through their treatment pathway, that the most of our patients will come into that low risk category. So this is something I think that we made a few years, 2 or 3 years ago, after going through both the BTA and the ATA guidelines. That's the British and American guidelines, plus there's quite a bit of discussion in various conferences around the world at the time. And so we came up with this flow chart really, and this is how we basically look at it in the MDT, looking at first their risk of recurrence based on the histology and ultrasound findings. And then beyond that, looking at what their response is to radioiodine. And then as we go through their risk, we then increase their TSH suppression, understandably. The big take home is actually the vast majority of patients don't need to be on massive suppression doses of TSH, which I'll come to why that's important, but I'm sure all of you being GPs understand why that's important. But the vast majority don't need to be on these high doses. And as where possible during their oncology follow-up, we will bring that down. And then over time, we can bring some of the other patients down who may be on higher suppressive doses of thyroxine down even further. Oops. So we look, when we're assessing their risk from their initial risk and then when they have the radioiodine, we have 4 categories. Don't worry too much about what those categories are. You may see those in our headers, in our letters, but the vast majority should come under the excellent response. So once they've had, whether they are intermediate or low risk, once they've had their radioiodine, and then we give them a follow-up for about 6 to 9 months after their radioiodine of just keeping an eye on the thyroglobulin, and then doing something called DRS, or dynamic risk stratification, which is where we undertake another ultrasound of the neck to make sure there's no localized recurrence without a thyroglobulin, which is their cancer marker, rising. And we do something called a stimulated thyroglobulin, where we deliver something called thyrogen or a recombinant TSH and do a blood test. And if both of those are negative, we can say they are of excellent response. From the point of view of our service, of how we then follow them up, is that we will definitely follow them up for 10 years doing a yearly thyroglobulin, whether they are excellent response or not. We are aiming to follow most of these patients up into low risk clinics. At North Middlesex Hospital, that's run by my endocrinology colleague, Dr. Garg. At Chase Farm, that's run by my endocrinology colleagues, Dr. Baines and Dr. Russell. And I don't think this affects you, but Princess Alexandra Hospital, that's actually now a nurse-led clinic and just having a yearly thyroglobulin. And the vast majority, that can be done remotely, so we don't need to see the patients. Hopefully meaning, obviously, stress levels are lower, they don't have to wait in clinic. And much like PSA follow-ups, it should be very low maintenance. Everyone else will be seen by an oncologist. When I say an oncologist, that's basically me, unless of course it's at the Royal Free Hospital, in which case it's my colleague Dr. Carr. This is the reason why this was in the last 10 years, why we've pushed for that, and I'm sure you're aware that with these higher doses of levothyroxine and higher TSH levels, they're much higher risk of various comorbidities, and obviously as people get older, these are more likely. So we're very mindful of this. We may start with higher doses of levothyroxine to keep them suppressed, but as time goes on and there's less likely and there's no recurrence and there's less risk of recurrence, we are very open to revisiting their TSH suppression levels and reducing thyroxine. So if they are discharged, say after 10 years, and maybe a few years later they develop something that we want to visit their TSH, we are more happy to then re-advise about that or see them about revisiting that. And that's my bit, but I'll hand you over to Yogesh again.
Great, thanks, Niraj, that's really helpful. And yeah, the first 2 years of our common practice together, Niraj and I spent reducing TSH suppression levels in low risk follow-up clinics, and hopefully that benefits a lot of patients. So the last bit of the talk really is about the rate of diagnosis of thyroid cancer, and are we benefiting our patients in the way that we are identifying lesions, and might we need to respond as a clinical group in terms of what we're doing. So if we could advance to the next slide. So this is not new. I mean, this is old data. This is whilst it says at the bottom 2012, actually it was Louise Davies, who's an ENT surgeon in Dartmouth in North America, who published in JAMA in, I think it was 2006, to describe the thyroid cancer epidemic. So we've had almost a threefold increase in thyroid cancer in the last 30 odd years. And as you can see, it's almost all papillary thyroid cancer. And follicular thyroid cancer hasn't changed much, poorly differentiated hasn't changed much, anaplastic hasn't changed much, and neither is medullary cell. So something's happening. The question is what's happening, and is this a real increase or is it something else? If we could move to the next slide. So what's going on? Interestingly, if you look at the mortality hasn't changed. So we have more papillary thyroid cancer. No one is dying any more frequently of papillary thyroid cancer. Perhaps you might say, well, we know that because you've explained to me that people don't typically die of DTC. If we look at the types of cancers that we're identifying, you know, over half of them will be lesions that are under 2 centimeters, and a good proportion of them will be lesions that are under 1 centimeter. And arguably, if you have a lesion that's under 2 centimeters, you may not be able to feel it. You might need to have another modality that lets you know that there's a lesion there. So sub-centimeter papillary thyroid cancer is contributing significantly to the number of patients who are being diagnosed with this disease. But these new tumours that we're diagnosing are not impacting on the overall mortality. Is that because we are absolutely in step, increasing our effectiveness at treating cancer at the same rate as the cancer is growing in incidence? Or is it that the cancer wouldn't have impacted at all on mortality in any event, regardless of whether we identified it or not? If we move on to the next slide. So there is a conversation about how to manage sub-centimeter nodules, and actually there was a conversation in the 1990s in Japan about how to manage not simply thyroid nodules but thyroid cancer that was of small volume. And this is Akira Miyauchi, and Dr. Miyauchi in the Kuma Hospital in Japan in the mid-90s appreciated that very small volume thyroid cancer might not progress into anything more significant. And so he identified a patient cohort and performed active surveillance of patients who had lesions less than 1 centimetre without neck nodes, and identified that only 8% of them had a lesion growth that was greater than 3 millimetres or 3 or more millimetres over a 10-year period. Now we've got to caveat this by saying that 4% of them manifested new neck nodes at 10 years, and of course the treatment of a neck node is quite different to the treatment of a micro PTC. But the take-home message from his study was that if you had a micro PTC and you were over the age of 70, chances are it may not grow substantially. And so we have started an active surveillance program for a small number of patients who have been referred on to us with very small volume disease. The issue still remains about what to do with young patients with small volume disease, and whether it is appropriate to be committing them to long-term follow-up, accepting that there is that small chance of them presenting with neck nodes. And Akira's data would suggest that perhaps younger patients might end up having surgery anyway, and we consider this to be deferred treatment rather than active surveillance for the under 40s. If we move on to the next slide. So I spoke initially about epidemiology and overdiagnosis. What is overdiagnosis? So the description, definition, is the detection and treatment of a disease that wouldn't otherwise have become evident in a patient's life. And the question is that true of what we're seeing here? And that the treatment can't help the patient, but only harm them because the treatment wasn't necessary. And you might say that's slightly contentious in terms of necessity or otherwise. It becomes very challenging not to offer treatment to a patient who's been informed they have cancer, regardless of how indolent you might tell that patient that the cancer is. And the last thing that's a really core take-home message is overdiagnosis, as Laura Davies will say, is an epidemiological phenomenon, and it isn't something that you can apply to a patient. So I'm here speaking to you as colleagues in the sector, saying perhaps we should think about how we are identifying cancer. But when I see that individual patient in my clinic room, I wouldn't use the term overdiagnosis. They are a patient with a tumour, and they have to be looked after with the best evidence. But when we're talking about developing practice guidance on a system-wide level, I think there starts the conversation around what we are doing to contribute to this phenomenon. If we move on to the next slide. And what are we doing? Well, in the 1950s and 60s, in Minnesota, patients were being referred on to the surgeons by neck palpation, but that's not how we identify nodules now. So the nodules have been identified currently on ultrasound, and a very simple way of remembering the typical incidence of lesions is that the percentage risk of having a thyroid nodule is pretty much proportionate to the age of the patient. So a patient in their 40s has a 30 to 40% risk, a patient in their 70s has a 60 to 70% risk. That's about right. Put another way, half of adults will have thyroid nodules, and the vast majority of nodules are benign, and potentially the more that we're accessing imaging, in particular neck ultrasound, the more likely we are to identify those nodules, and so question whether they might represent lesions of interest. If we advance to the next slide. So question, does papillary thyroid cancer qualify as overdiagnosis, or does the rise rather in the rate of diagnosis qualify as an example of overdiagnosis? Well, we know that the cancer diagnostic rate has tripled in 25 years, the majority of which are subcentimeter cancers. We know that autopsy data describes, and this is old data from Finland in the 70s, that potentially up to 60 to 70% of thyroid glands at the time of death harbour microcancer. We know that there is a system by which we as a community of doctors are contributing to the diagnosis by the use of imaging and ultrasound and FNA, etc. And the other thing to say is there a reason why we might be diagnosing more that can't be explained by ultrasound? Is there something going on in the environment that is the real driver? Is there an issue regarding radiation, etc.? We don't believe so. So the only bona fide risk on multivariate regression is, beyond the genetic risk factors of familial cancer, is exposure to radiation in the developmental years, and also obesity. Hashimoto's is a little bit contentious. If we move on to the next slide. So this is a take-home message. We are identifying thyroid nodules by way of ultrasound, and that really is driving the increased rate of microcancer diagnostics. And of course, once we inform a patient that they have a nodule that we suspect to be tumour, or indeed is diagnosed as a cancer, then we have a duty of care to follow them up. And that follow-up, if we are engaging with the thinking of Akira Miyauchi and Mike Tuttle in North America, might be that we start to develop sizable follow-up clinics for patients who have small tumours. If we move on to the next slide. So my interest in neck ultrasound grew when I was on my head neck cancer fellowship, and I was working with Steve Colley up in Birmingham, and I appreciated that in order to be an effective head neck surgeon and an effective thyroid surgeon, I needed to learn neck ultrasound. So I started on a journey, a 3-year journey of performing neck ultrasound scans on the weekend under the direction of a colleague in Barnet, and I joined the British Society of Head Neck Imaging. And I pulled together data of the first 1,000 patients that I scanned, and I thought it would be of value because it would tell us something about the indications for these scans. So a retrospective audit of data that was prospectively collected between August 16 and February of last year. If we move on to the next slide. So the vast majority of neck ultrasound scans that I was performing that were being sent into Barnet were from primary care. A smaller proportion, less than a quarter, is combined specialty referrals from ENT, maxillofacial surgery, and also from the endocrinologists. If we move on to the next slide. And this is what we might expect, that patients who present to us with thyroid lumps or who are presenting and being referred on are more likely to be female than male. And the age distribution is, for the most part, of people who are in working age, if we advance the slide. And this was the outcome. These are the indications for scanning. Now, this was pulled together by a registrar who's now left the department, and so I guess the first question might be, what might you consider to be non-specific clinical information? So I would, we categorised against the hard indications, or that an individual might consider a hard indication, and then if there wasn't anything beyond query thyroid fullness, that went down as non-specific clinical information. So beyond that, the common reasons for requesting ultrasound scans appear to be abnormal TFTs. So hyperthyroid, I'd like a scan. Hypothyroid, I'd like a scan. And if we look then against the BTA guidance, there isn't much of a role actually in neck ultrasound to identify someone's thyroid function. There's a question about surveillance of a known nodule. And we might suggest that if a patient has been described as having a benign nodule, there isn't any absolute need for that person to be having ongoing frequent ultrasound scans. Now, I appreciate that we don't live in a vacuum, and the European experience, which is fee-for-service, might encourage a system whereby patients have successive neck ultrasound scans, but it's not the system that we've developed in the UK, and it's not what is supported by the BTA. And the other thing to talk about is globus pharyngeus. It's not uncommon for patients to be referred on with a sense of something in their throat, and I might suggest that if you can't palpate a fullness that might suggest a thyroid mass, then perhaps a neck ultrasound scan isn't required. If we advance to the next slide. So this was something drawn from an advice and guidance request on ERS, and the question is, what should we do? So this has not been changed. This is what we received. An 87-year-old recently diagnosed with dementia and hypertension has a sense of something in her throat, and the ultrasound scan shows something. And so we might ask the question, okay, if an 87-year-old with dementia might have a palpable mass, might we want to do something? And if so, who should we refer to? If they have a sense of something in throat, do we think that an ultrasound scan is the right test to be performing on this patient? And possibly not if they don't have a palpable mass to feel. If we move on to the next slide. So this is the NICE guidance as things currently stand, and NICE are developing guidance on the management of thyroid cancer, and they started this conversation pre-pandemic, and the suggestion was that they were going to be publishing something in 2021, though that might be deferred at some point in the future. But I thought I would take out the highlights for when we might want to do a scan. So the first thing that they talk about, only consider an ultrasound scan if the patient's thyrotoxic with palpable nodule. It's interesting. Why might a patient be thyrotoxic with a palpable nodule? Might they have Graves' disease? If so, would an ultrasound help you treat them? Possibly not. We might beta block them and start them on carbimazole. If they have a toxic adenoma, would that be of help in primary care if you knew that? Perhaps not. If they suffered from acute thyroiditis, that's an acutely painful gland with thyrotoxicosis, possibly. But that's pretty uncommon. So perhaps the management of thyrotoxicosis should be in the presence of an acutely painful gland. But otherwise, there might not be an absolute need to be ultrasounding someone with thyrotoxicosis per se. Otherwise, the question really is about the risk of malignancy, and the suggestion is that you should do it if you suspect malignancy. And so the question is, what might you be looking for in that to establish whether someone may or may not have malignancy? And if we move on to the next slide, see if it's there. Yeah, so again, a sense of compression or malignancy. So what are we talking about? We're talking about hard nodules, fixed lumps, voice change, lateral neck nodes, and truly that means sort of T3 disease. That's what NICE is actually pointing towards, because of course, if you consider the disease I was talking about before, the sub 2 centimetre disease, that will very rarely cause hoarseness, voice change, fixity, or anything else of that nature. In terms of compression, in the absence of a palpable mass, it is quite unusual for a thyroid gland to be causing intrusive compressive symptoms. If you can't see it and certainly can't feel it, it's most unlikely that it's the thyroid gland causing the compression. And so perhaps a neck ultrasound scan won't give the answer, and then it requires us to be using our clinical judgment as to whether they might have globus pharyngeus. And if we move on to the next slide. Great, and so monitoring, and again, this is NICE guidance, and we look to be adapting it locally. The take-home message here is that if a experienced radiologist using good quality equipment is describing a nodule as being benign appearing, we wouldn't suggest that they need ongoing imaging, because the risk of missing malignancy is actually incredibly low. When might we suggest they be referred back? If there's a substantial change, if a patient has a significant change in the volume of their gland, absolutely right, they should be referred back, but no indication to be repeatedly scanning if a patient's been determined to have a benign nodule. Next slide. So yeah, as I said before, when to suspect. So you've got these clinical factors on examination. You've got a fixed lump, lateral neck mass, voice change, pretty uncommon things. All the risk factors, the personal risk factors are neck irradiation or family history. And really important to say that family history doesn't mean one person in the family having differentiated thyroid cancer. Likelihood is, even if a second person has thyroid cancer, that it probably isn't familial. Familial, and to give it its full title, familial non-medullary thyroid cancer, i.e. the papillaries and folliculars that are germline, that are more likely to happen because of mutations in the germline, actually require 3 individuals who are first-degree family members to be diagnosed for us to say it is for sure thyroid cancer. So thyroid cancer in the family shouldn't lead to other members of the family having neck ultrasound scans, because that strays into screening, I think, if we move on to the next slide. So the question is, what should we be doing in terms of neck ultrasound? What sort of advice should we be doing about what is appropriate and what we could be doing differently? There's an ongoing conversation within the sector about how we present the advice to colleagues in primary care. This is a slide very kindly shared by Polly Richards at Barts, and this is what they have done for NEL, which is a sort of traffic light approach of what is reasonable and what might not be necessary, and hopefully we can develop something like this in our sector as well. And if we move on to the next slide, and this is a key take-home message. The US Task Force for Preventative Services, basically looking to ask the question, is screening effective for any given population, recommends against the screening of thyroid cancer in asymptomatic patients. And you might well ask the question, what does it mean to not have symptoms? So, of course, to be hyper or hypothyroid is not a symptom of thyroid cancer. The symptoms that they're talking about is a palpable and firm nodule, or a palpable nodule that's asymmetrical, a rapidly growing mass, or a lateral neck node. So patients who don't have palpable abnormality would qualify for the US task force, because being asymptomatic, and the recommendation is please don't do it. And that's because thyroid cancer is one of the leading causes of medical bankruptcy for patients in North America, and there's an increasing cohort of patients who are taking their physicians to task for requesting the scan in the first instance, because they'd rather not have known they had a nodule there in the first instance. And if we move on to the next slide. So what would we like to see in a referral? It'd be great to know the thyroid function, and also if that person is euthyroid because they're on levothyroxine or because they're on antithyroidal medication. Patients with Hashimoto's thyroiditis will have a heterogeneous gland, which will demonstrate pseudonodules that might otherwise cause concern to a radiologist if they were not to know this. A history of radiotherapy at an early age, of course, is a risk factor, and a family history. More than 2 patients, or 2 people rather, in a family is a risk factor. And then, of course, the other obvious things that we'd like to know about is if they have a fixed lump, an asymmetry and rapid voice change, which are very unlikely. But of course, they should be referred in directly to us. And the next slide. So another important point from Ankie van Haften, who is a patient in the Netherlands, who wrote a blog which became a book. There's no such thing as a good cancer. So I have said that it doesn't kill people. I have said that people might live a very long life regardless, and that surgery is fairly straightforward. But if you ask the question to a patient, how do you feel a year or two after being diagnosed, they still have concerns. They worry. They worry about their day-to-day life. They worry about recurrence. And they worry about what the future might mean for them, regardless of the size of cancer. So it's one thing to say, it's okay, you'll live a good long life, but actually we are doing harm, and it's not just physical harm from thyroid surgery. Actually, there's a degree of psychological harm from diagnosing patients, especially those patients who might not have come to harm had we not diagnosed them. And if we move on to the next slide. So this is a little bit tongue-in-cheek if we advance. Yeah, so it was just to say, let's have a discussion, let's have a think about patients who are referring on for neck ultrasound scan, because once we've started this journey, a proportion of them will end up undergoing surgery and or being given the diagnosis of thyroid cancer that really is impacting on their quality of life. Next slide. And these are the paradigm shifts. A reduction in TSH suppression, perhaps not needing so much radioiodine, perhaps we're offering therapeutic lobectomies and not removing glands, perhaps we're not removing glands at all, and maybe we're monitoring nodules in the community. So these are some of the changes that we foresee in the next 5 years. Next slide. And Thomas Kuhn wrote about paradigm shifts, and for us to understand where the shift might happen, we need to collect data, we need to be thoughtful, we need to be consistent in how we're working, and so having standardized protocols is of real value, and I'm very grateful to Neeraj and the rest of the team in helping to deliver this for us. And next slide is a thank you to the rest of our team who are instrumental in delivering our service. And that's everything.
Claire, you're on mute.
Thank you. Thanks very much, both of you, for that really interesting talk. And we've got quite a few people still with us. I haven't seen any questions posted in the chat, clinical questions, so I'm going to ask one, if that's all right, around voice, what you described as voice change. So quite often in primary care, patients will may come and talk to us about a croaky throat, sometimes that they feel as if they've got something, you know, stuck in their throat momentarily, and that affects the way they speak. But then quite quickly they clear their throat and their speech is then normal. Can you give us a feel from a history perspective of how important it is, or how prevalent it is that you get changes in voice in any particular patient that are persistent, as opposed to temporary or recurrent?
Sure. So, let me start by talking about it from a thyroid cancer perspective. In my 5 years of practice, I have seen 2 patients who presented with dysphonia because of their thyroid cancer. Now, we have patients who have node involvement with their nerves, but it's incredibly rare. Now, I understand why the guidance talks about it, because if it were to happen, of course, it's a red flag for an invasive cancer, but actually it's fleetingly uncommon. And for that reason, I might suggest that if there's a concern about voice, our focus should be on whether we are missing a glottic lesion. And that's best served by performing a fibre optic nasal endoscopy. So I'd much rather actually patients are referred in if there's a genuine concern about voice change being cancer, that we see them in clinic for a nasal endoscopy rather than a neck ultrasound scan. And an ultrasound you might consider to be more accessible and perhaps less expensive, but actually, you know, it won't give you an answer and perhaps might tell you something that you didn't want to know. In terms of what to expect from a history of someone with potentially non-concerning voice change, it's that fluctuation. It's the fact that it comes and goes. There are other features that I guess contribute to dysphonia that are related we believe, to conditions like laryngopharyngeal reflux. It's very common. I'm sure any one of your colleagues who's had a patient referred to ENT, quite oftentimes we say, well, patient might have reflux, and that can be the case. And so their gastric contents cause irritation, a little bit of edema. They talk about the need to clear the throat, a sense of mucus. They point to their cricoid and say there's a bit of tension there. The voice changes, it's a bit irritable, but it fluctuates. And they drink a glass of water and the sensation gets better, and that sense of globus is relieved when they sip some water, cool water. So all these things are pretty reassuring to us, but it does require a degree of confidence to have heard that story before to say, yeah, this is probably globus. But my message to colleagues is, look, if a patient has a history of smoking or significant alcohol consumption, regardless of whether it's fluctuating, if you've got concern and it's been there for more than a month, send them in for a scope, and we'd happily scope them. But much better to scope them than to ultrasound them.
Right. Okay. Thank you. And a follow-up question. I'm keeping an eye on the chat as well, but a follow-up question on that, particularly because of what we've had in the news yesterday around women getting better with HPV screening and self-screening for cervical pathology. That may bring the dialogue from patients around their concerns around HPV and throat problems. Do you ever see voice changes accompanying early presentation of HPV disease in the throat?
It's a very good question. From a cancer perspective, not so much. Speaking as an ENT surgeon, primarily, first and foremost, RRP in young children, I'd imagine. So if we think of the pediatric population, what's the most common cause of hoarseness in youngsters? Probably vocal cord nodules, actually, persistent hoarseness. Right. But second comes RRP, and that really devastates the lives of youngsters. And if we could drive down the prevalence of HPV in women of childbearing age, then we could make some inroads into that. In adulthood, the HPV-driven cancer tends to be oropharyngeal, actually, rather than laryngeal. Tends to be tonsillar, tongue base, etc. So, we see it often. Patient with an asymmetrical tonsil, don't be shy to refer that in. Despite the lack of smoking history and alcohol consumption, we see patients in their 30s presenting with these tumours. And of course, if you were to have a patient who has a lateral neck swelling and they have a neck ultrasound scan and the result comes back, it's a simple branchial cleft cyst, and now we used to in the past say, sure, it's a late presentation, but for us now, first question, HPV-driven cystic MET, or even papillary thyroid cancer cystic MET, we take seriously cystic lateral neck lumps. Right.
Thank you very much. Thank you. Catherine, can you just reassure me I haven't missed any questions?
There is one that's come in.
There's one now. Okay.
About an algorithm. Can you see that?
Do you want to just read it out for me?
Okay, yes, I will. Can we have an algorithm for how likely GP to initially investigate a feeling of globus? Sorry, I'm sure if it's quite clear. Yes.
Yes, I mean the question just is, can we have an algorithm for how you would like? I think it's how you would like GPs to initially investigate a feeling of globus.
Thank you. Thank you.
Yeah. It's a great question, and it's something that we haven't formally developed, and we can certainly work towards. Interestingly, because of COVID, there was a substantial change in how we worked as cancer diagnostic clinicians, and we shifted towards a telephone-based system. And the drive then was about the history. Yeah. And there was actually, for the East London axis at least, they described a symptomology that their registrar, I think, had called FOSSIT, which stands for feeling of something in throat. I think that's sort of globusy type sensation. So, yeah. I would go back to basics. It's a question of taking a history, looking to see whether it is persistent or otherwise. Is it progressive? Are there any other red flag features of head and neck malignancy? Are there any risk factors? Have you tried the patient on dietary modification and or PPI and Gaviscon? And if things haven't resolved after a 6-week period of that, then absolutely consider referring them on. But we'd be happy to see them if there is a genuine concern that they might have a tongue-based lesion that can't be seen, or a post-cricoid lesion that can't be seen. Very happy to see them, but I think the take-home message really is a neck ultrasound scan will not give you the answer. Even if they were to have a base of tongue pathology, giving them a sense of feeling of something in throat, a scan of the soft tissue in front of the trachea, which of course sits in front of the esophagus, won't give you the answer, but it might yield an indeterminate nodule that leads you down another path. Yeah.
So endoscopy will give you the answer only.
Well, quite, yeah, and some ENT clinicians might suggest that that a history in itself is enough, but for those patients where there are risk factors and there are concerns, then perhaps a fibre optic nasal endoscopy is that assessment that provides reassurance to all that we're not missing something.
Yeah. Okay. Thank you very much. Right. I think as it's 1:30, we'd better draw things to a close. I think I take from that and the way what you've spoken about in the webinar today. And we had already arranged, Yogesh, hadn't we, to do this. We'll have a look and see if we can find, think of ways that where algorithms or equivalent might be helpful, even if it's perhaps not an algorithm in this true sense, but some headlines about red flags and quite how to manage things, and where things where perhaps we're reaching for ultrasonography in general practice because we're not quite sure what else to do, and perhaps what our other options are. That's really helpful. Thank you both very much. We learned a bit of physics too, so thank you. I wanted to ask about proton beam therapy and instead of surgery, but we'll leave that for another webinar. But thank you both very, very much. Thanks to Catherine and Vanessa from the team for putting this together. And just to remind everybody, and perhaps you can tell your your colleagues and friends, remind them that we've changed the way we register for the webinars this term, so that if you just register once, we then have your email address and we can then send you invites for all of the events that we do straight into MS Teams. And if you'd like to come, please accept. If you can't, you can decline, but at least, or if you're not quite sure, you can put maybe, at least that initial acceptance, that single first response will allow us to continue to contact you, GDPR and all the rest of it. Thank you very much. Thanks very much, everybody. Thank you.
Thank you.
Thank you.